I am Dr. Naim. Today I'm going to discuss about uh, renal reabsorption. Just I will try to give an overview and effect of ADH and urea. So in short, if I try to say, in PCT both water and solute sodium chloride reabsorbed. In descending loop of Henle, only water reabsorbed, water out. Then loop of Henle also does the same. Ascending loop of Henle, only solute out, sodium chloride out, or sodium chloride reabsorbed. Then distal convoluted table, also solute reabsorbed. This is proximal portion of distal convoluted table, and distal portion of distal convoluted table and collecting duct reabsorb water in response to ADH. If ADH is absent, this portion doesn't take any water out of the tubule. So now I want to show you a diagram. In PCT, both water and solute out. Here is osmolarity is 300 millismol per kg, and it, as the both water and solute is out, the osmolarity remains same, 300. When we show the descending limb of loop of Henle from proximal convoluted tubule, water is out, so osmolarity is going to rise 400, 700, 1000 as water is out. So this portion water is out, the osmolarity is 1200. And in ascending limb of loop of Henle, here solute is out, sodium chloride is getting out, so osmolarity will go down 800 to 500. Again sodium chloride is out, solute is out 200. And in this proximal DCT also sodium chloride is out, and this is the lowest concentration if ADH is present. Okay, now look, when distal DCT and collecting duct, here water is out, water is out, water is out, water is out in response to ADH. So ADH was through aquaporin channel and brought this water out. So osmolarity again going to rise 100 to 300, 300 to 500, 500 water out, then it goes 900, and again water out is the 1200, the highest osmolarity. So if I say in presence of ADH, lowest osmolarity is found in proximal distal convoluted tubule, early distal convoluted tubule. Sorry, this is not proximal. This will be termed as early distal convoluted tubule, and the highest osmolarity should be at collecting duct, as the patient is in dehydration, and body tries to reserve water. So water is absorbed with the help of ADH. Okay, so now I'm going to show you another figure. In this figure, this green colored margin area is permeable to water. Okay, is permeability of nephron to the water. So proximal convoluted tubule, then descending limb of loop of Henle and half of loop of Henle is permeable to water. Then ascending limb of Henle and early distal convoluted tubule, this is impermeable to water, but permeable to solute. Sodium chloride. So, and the late distal convoluted tubule and collecting duct is variable. So this shows orange or yellowish color. So distal convoluted tubule, late portion, and collecting duct portion is variable. If ADH is present, water is absorbed, and if ADH is absent, water is not absorbed and is done through the collecting duct and make urine. So in normal condition, water is out in the absence of ADH. No ADH. In proximal convoluted tubule, both water and solute is out, so concentration remains the same. Here water is out. Now solute is out. So 120 milliosmol per kg. This is the concentration at early distal convoluted tubule. As when it goes to late distal convoluted tubule, then again some of the this osmolality goes down, and in collecting duct it also goes down. So in this absent of ADH, the lowest osmolarity is in collecting duct and highest osmolarity is in loop of Henle in this area. Okay, then I'm going to discuss the effect of urea on water absorption, and the also the effect of ADH. So urea is absorbed in proximal convoluted tubule, then it comes loop of Henle, then it again through the ascending limb of loop of Henle, it comes the medullary portion of collecting duct. This is cortex and this is medulla. This is medullary portion of collecting duct, and this is the interstitial space, and this space contains urea. When a person is dehydrated, he cannot take water, dehydrated, and decrease water in body. So when water is absorbed in this area, when comes to this area, this interstitium is of very high osmolarity, and think urea presence here, think this is osmolarity of 500. So this high osmolarity area draws water out, and the osmolarity here comes to think around 800 as it draws water. And another thing is when water is absorbed to the interstitium and it goes back to blood water, when this urea when water is out from the collecting duct, then urea concentration within the collecting duct decreases. When urea concentration here was bigger, then water got out, and this concentration of urea now decreases. So, and in the collecting duct, urea concentration is higher. So urea comes to the interstitium by passive diffusion through its concentration gradient. Look, this is 500 milliosmol and there is 300 milliosmol. So from 500 to 300, the urea will shift from high concentration to low concentration, and this will happen occur passive diffusion, through passive diffusion. So when water is out to the interstitium, then urea concentration within the collecting duct rises. So and here urea concentration goes down, so urea come out of collecting duct to the interstitium, and also in this area, in the loop of Henle, urea concentration is lower than this interstitium, so interstitial urea will go into loop of Henle. So and again maintain the concentration gradient. So urea diffuse through this interstitial space towards the concentration gradient by passive diffusion into loop of Henle. So this area again urea against go through this pathway and again comes to the collecting duct and helps to absorb water in this interstitial space. Urea maintains high osmolarity, so water is drawn out of collecting duct, and urea then goes to the loop of Henle. Again urea is cycled to the collecting duct, and this process goes on until the person is rehydrated. So this is the effect of urea to reabsorb water. You can see here urea recirculates from inner medullary collecting duct into medullary interstitium and thin loop of Henle. So first thing is urea medullary collecting duct. This is medullary collecting duct. Okay, it's comes urea goes from medullary collecting duct to medullary interstitium. This is medullary interstitium, and then to the loop of Henle, and thus it maintains a concentration gradient. Now the thing we need to know, why this urea concentration is important. It's important due to, as urea helps to absorb water. So this we can correlate with another pathology, that is in acute renal failure. We classify the acute renal failure into three types. One is pre-renal azotemia. The next in post-renal azotemia, and the third one is intrarenal azotemia. In prerenal azotemia, it is due to decreased blood flow to kidney. So kidney cannot work properly, decrease GFR, but as the kidney is intact, kidney will try to absorb more water to maintain volume. In prerenal azotemia, we see we discuss about blood urea nitrogen. So as the kidney is intact, blood urea nitrogen or urea mainly is high to concentrate urine, and creatinine is low as kidney is still functioning. So whether kidney function is intact or not, that can be understand by seeing blood urea nitrogen level. In prerenal azotemia, blood urea nitrogen or urea is more. We see blood urea nitrogen is to creatinine ratio, so it should be 20:1 or more than at least more than 15. Then as the kidney is intact, if in a fractional excretion of sodium, it will body will try to conserve water, so sodium is also reabsorbed, and the amount of sodium will pass through urine is very less in urine. So FeNA should be less than 1%, and urine osmolarity is more than 500 milliosmol, as urea absorption ability is good, so the sodium absorption will occur, and urine osmolarity should also be more than 500. In postrenal or intrarenal as intrarenal azotemia, the urea absorption is not normal. Less urea reabsorption, so blood urea nitrogen into creatinine ratio should be less than 15:1. So creatinine will rise in this case, internal azotemia, and also as kidney's function is deteriorating, so the fractional excretion of sodium should be more than 1%. Sodium is lost, secreted sodium is lost through urine, and urine osmolarity should be less than 500. So thus urea is important in maintaining the osmolarity concentration of urine. So I think in post-renal azotemia, if I discuss post-renal, there is something obstruct the uh, obstruction occur, like stone or other thing. So in the first stage of stone like this, when kidney remain intact, then burn and creatinine ratio should be normal, like 15, and in the long run, after a few days, uh, as I want to draw a figure. So when there is obstruction, like here, obstruction, then there is stasis of this fluid. So the in post-renal cause, the hydrostatic pressure will increase in this case, and this as this component need to get through the collecting duct and ureter, so some obstruction has made it to backflow, and it is coming above, and ultimately it when this process continues, then the hydrostatic pressure increases in the glomerulus, and interstitial pressure also increases. So when interstitial pressure increases, then the glomerular GF glomerular filtration rate will decrease, and in the late stage we find blood urea nitrogen is low, as urea cannot reabsorb properly, and creatinine ratio should be high. So blood urea nitrogen into creatinine ratio should be less than 15, and fractional restriction of sodium also more than 1% sodium will be excreted, and lastly urine osmolarity also less than 500 milliosmol. So this is the thing I think we need to understand about the urea mechanism, urea recycle in the kidney to maintain the concentrated urine. Thank you.